Now we move ahead to the next session, which is very important session, presidential oration. And I would like to invite the chairpersons, Professor Gauri Devi, Professor Devashish Chaudhary, and Dr. Chabra, Dr. S.S. Chabra. I request them to take over the session. Thank you.
Okay, Achal, can you tell them the organizers to start my video because they have blocked it?
Okay, sir.
The host has stopped my video.
Yes, sir. It is running.
Can you see me?
Yes.
Right. So, good evening, ladies and gentlemen. Today and at this hour, I think it is delayed a little bit. We are waiting eagerly for the most important event of the Dnacon, that is the presidential oration. And for that, I would now request Dr. Chabra to kindly invite Dr. Achal Srivastav, who will be introducing the president of DNA, Dr. Amitabh Verma. We are all eager to hear the presidential oration. Dr. Chabra, please. Okay.
Yeah.
Dr. Chabra, could I kindly invite the, I think Dr. Achal is going to introduce our president.
May I invite Dr. I can't switch on this video, is not working. Anyway, now I invite Dr. Achal Srivastav to introduce. Right. Can you see me now?
Yes, sir. Not coming, still not coming. Sorry.
Yeah. Why is this not working?
You started the video, sir, from your side.
Sir, already I request start the video.
Okay. I don't know why. Anyway, I invite Dr. Achal Srivastav to introduce our president of the DNA,
Okay.
Amitabh Verma. My video there is some problem with video. I don't know why it is not working. Dr. Achal Srivastav, please.
Yes, sir. So as I'm thankful to the organizers and as well as Dr. Devashish, who asked me to introduce Dr. Amitabh Verma, president of DNA. So now I will disappear and you will see me in the virtual auditorium. Thank you.
Once again, I welcome you all to the Dnacon 2021, which is 23rd annual conference of Delhi Neurological Association and 19th Neuro Nurses Forum. I have great pleasure and feel proud in introducing our president, Dr. Amitabh Verma, the man in white. He was recipient of gold medal for being all-round best student of Gandhi Medical College, Bhopal in 1971 and completed his MD medicine in 1976. He did DM from Neurology Department of AIIMS in 1979 and now he has 45 years of active clinical neurology. He was someone neurology admissions of patients under neurology services in private sector hospitals of Delhi, replacing the established practice of admission under medicine department. He was faculty at our department from 1979 to 82. He started neurology in Batra Hospital in 1986. Later, he shifted to Indraprastha Apollo Hospital. Further, he went on to Max Super Specialty Hospital. Currently, Sciences Department of Supreme Hospital. He was the first neurologist of India to be appointed to President of India in 1988. He has been corresponding fellow of American Academy of Neurology. He is chairperson of international conferences, scientific sessions and various conferences and sessions, various forums and various associations. He is honorary science at MVB Holland. He is member of board in 2005 to 2007. He was on editorial board of JAMA India from 1991 to 19. and he was actually organizing secretary of Indian Academy Neurology Conference, which was organized in 1994, New Delhi. He is visiting fellow with Dean of Stroke Professor James F. Toole with North Carolina. He is an astrologer of repute. Astrologers. He is a spiritualist and used to speak on Rig Veda with Maharshi Mahesh Yogi on his Maharshi TV channel. He is chairman of Contemplative Neurology subsection of Indian Academy of Neurology and Cognitive Neurology. He was actually a good cricketer and played against Gavaskar somewhere in 1970 in an inter-university competition. He has been captain and a very good TT player. I have personally seen him various photographs. He has been a very nice photographer, and he is a member of reputed India International Center and India Habitat Center. Now we take you to the photographic memory of his. Here we see with various presidents, with Madhya Pradesh CM Shivraj Singh Chauhan, which is actually his home state, his father and mother. He has been a family man, you can see in this picture. And here we see very, very young Dr. Verma with his young family, and that is what I say, Navyog Dr. Verma. Thank you.
Thank you very much, Dr. Achal, for these lovely kind words about me, especially taking me to the journey of my life. I am especially delighted to see my young children also in the photographs. Well chosen. Thank you very much. Now, please lend me your ears. Good evening, my colleagues. This evening, before I start my oration presentation, I would like to pay my respect to my guru's parents, that is my parents, Professor Rajan Verma and Srimati Nirmala Verma, who are no more, but who always guide me. And also to my visionary teacher, Professor Vimla Vermani, who has taught me neurology, initiated me into neurology. Well, before coming here for the conference, I am sure you must have been used to getting stuck in some traffic jam in various highways, or for any reason. There can be a traffic jam because of potholes on the road also. It need not be there, it can be at distant places also. Similarly, brain also has highways and small ways. Highways are in the white matter, and if the highways all have potholes, then also you get traffic jam, that is the communication through the tracks get delayed. There are various white matter tracks, I need not tell you all, because they are very much known to you and we can see them by tractography. There has been a lot of improvement in the cartography, mapping. We can see the map, Google map right over here. For brain, from phrenology, we have come to connectomes, but still the maps are not yet fully developed. We are still working on it. For these maps, these will be required because 160,000 kilometers of axons in white matter are connected and function, because neurons that fire together, wire together. What makes us think, love, play chess, talk and tick? It's the connections, the wiring of the brain, physical wires, axons, synapses, etc., and the strength of the connection. There is functional connectivity. I must tell you, we have macro connections, micro connections, dendrites, synapses, but they may not be seen in the regular MRI and CT scan. Therefore, people call it brain is normal, but limitation should not be misconstrued as ultimate truth. जो दिखता है वो होता नहीं और जो होता है वो दिखता नहीं. There are three types of connectivity: structure connectivity, functional connectivity. Functional connectivity both static and resting. Myelin and myelin maps, third type of connectivity. What Gates said was we should look not only to the near future, but for the distant future also, that is more important. And that is why looking at the distant future, these three stalwarts worked hard and brought to us what is going to be connectome. Von Essen, Masolem and Zillis, who died last year unfortunately. These are the white matter tracks which I have shown you at different places, and these are the highways. And in children also we can have these tracks developing in different stages, we can see them. Some of the tracks are very important for behavior, for memory and for motor movements. There many connections are, when disconnected, are not visible, like these potholes. They are known as connectopathies. Well, these are the common pictures which you have seen, white matters, hyperintensities. Are they really of any significance? Usually in the report you see age related changes, so people take it of no consequence. However, the study, the meta analysis in BMJ, systematic review and meta analysis, showed that there are a lot of consequences. They put the person at risk of cognitive impairment 2-fold increase, and the risk of dementia is a 3-fold increase. Also it produces walking difficulties, motor improvement, abnormal gait, but they can be reduced by walking and movements and exercises. They can be worsened by aggressive lowering of the blood pressure in the elderly. Studies after studies have shown the memory changes are related to its load. At one place you can have more load, that is the anterior portion of the brain. People have also found that enlarged perivascular spaces are also associated with cognitive impairment in healthy elderly. In brain 2019, they have shown it to be a biomarker for identifying individuals in midlife. But how to differentiate various hyperintensities? Why do they call them? The best way to differentiate is FLAIR studies, FLAIR sequences in MRI which show hyperintensities like stroke, but a stroke can be differentiated, whereas the rest of the thing like perivascular spaces and lacunes do not show hyperintensities in FLAIR images. These things can shrink and enlarge also with passage of time. Is there neuropathological correlation? What is the evidence that they are of significance? Postmortem MRI has shown that that area was MRI was taken and it showed histopathological correlation in terms of microglial and endothelial activation. Mind it, blood vessel involvement. Same thing was shown in the neurology, American Academy of Neurology, that it involves a loss of vascular integrity. In a stroke journal, they went a step forward and showed microglial by immunohistochemistry, microglial involvement. So blood vessels are involved, inflammatory cells, microglial activation is there, endothelial activation is there. And DTI also shows these changes are of consequence. When the tracts are involved, then you get less outcome in the stroke, and if it is in the small vessel area, then produces cognition. In the multicenter study it was shown. It has a ripple effect. You have a stroke here like a pothole, a traffic jam in one place has a traffic slowness and a distant radial places also. Same thing here, you can have distant changes. It also produces progressive impairment in the walking in the elderly. DTI has shown that. Now, what is the importance of the load? Especially at the centrum semi-ovale, if it is involved, if they are present, then it changes a lot of cognition. They can also involve the cholinergic pathways also and produce depression and dementia both. So it need not be motor pathways. Well, there is enough evidence, gentlemen. Neuropathological clinical studies, meta reviews, it is not isolated studies, there are meta analysis, systematic reviews which show that it is of significance, and not to consider it as a age related only. It happens in a particular age, does not mean that it is age related. Well, there is enough evidence, but talking of the evidence, Now, I will come to the other pothole. Second pothole, that is EBM. Yes, sir, you will be shocked. Evidence, I am going to present evidences against evidence based medicine. This is a superman, superpower in the medical sciences, but I am going to challenge it by giving evidences against it. In 1991, when Dr. Gayate coined the term evidence based medicine to describe a new method of training internal medicine residents at McMaster University, but his mentor David Sackett took it forward and made it so popular, authoritative. He wrote an editorial in 1996 in BMJ, where he said it, headlines was, it's about integrating individual clinical expertise, mind it, individual clinical expertise and the best external evidence. Well, evidence based medicine, you can see in this BMJ article, it's about integrating individual clinical practice and best external evidences. These are two pillars, but unfortunately, of the two pillars of this balance, one of the pillar has been misquoted and misused. David Sackett had called individual clinical expertise proficiency and judgment that physicians acquire through clinical practice. So, both should be equal, integrated, but nowadays what is happening is it has gone down. Clinical expertise has not been given importance. The lab investigations have been given importance. Hierarchies of evidences have changed. Instead of equal importance, it has changed, with the result that you see the balance has been tilted, weighted. But what you learn in your medical school changes in the next 5 years, which half is to be seen. That is what David Sackett has said. The most important thing to learn is how to learn on your own. So, we are learning on our own. Now, there is crisis in evidence based medicine because of the quality mark has been misappropriated by vested interest. I will justify that, this statement, this assertion. There are too much of evidence, benefits may be marginal and management driven, the whole things are management driven rather than patient centered. Evidence based guidelines often are poorly mapped to complex multimorbidity. Burden of the proof is on the clinician in the interest of the patient. The first problem is that the evidence based quality mark has been misappropriated and distorted by vested interest. What evidence you see is not the full evidence. 2/3 of the evidences are underneath, patient values and clinical experience. Evidence, broadly speaking, intellectually evidence is obvious, you do not have to prove it, but the empirical evidence requires proof, you have to prove that it is evidence. A doctor who is supposed to take a spur of the moment decision, emergency, has to rely on the protocols, algorithm, cannot take any other using her or his own experience, even if the person is senior enough. But pilot, to save 200 lives, can take any decision based on her experience or his experience. So, now there is a top down or bottoms up. What is the decision we have to take? What is the changes? What are the changes now? The backbone of all evidence based medicine is statistics, and that is why it has given emphasis on experimental evidence, and the tacit knowledge that accumulates with clinical experience has been given a second place. There has been misuse of statistics in medical research, and there is statistical jugglery. Before that, I would like to make it clear that there is a difference between clinical and statistical significance. statistical significance refers to the influence of chance on the outcome, whereas the clinical significance refers the biological value of the outcome. Statistics are derived from groups of individuals. Medicine is practiced on a specific individual. Anything can be gone through this, can be put to statistics. Now, the backbone of evidence-based medicine has to suffer a lot when, that is p-value, when article in Nature, the authority in science, hard sciences also, when Professor Ragina Nazu from Washington wrote an article and proved the point that p-value, the gold standard of a statistical validity, are not as reliable as many scientists assume. This was shocking to people who took as a absolutely gospel truth. The irony is that when UK statistician Ronald Fisher introduced the p-value in the 1920s, he did not mean it to be a definitive test. You can play with p-values. How? You can overpower it, vested interests do it. So, the small differences will be statistically significant. Like in this study, 25 patients, p-value is not significant, but you make it 100 patients, overpower it, then you make it significant. It is like coin, how much you toss it, so the difference changes. Vested interest also change the inclusion criteria, the endpoints, surrogate endpoints. Now, for that, another thing is happening which is known as p-hacking. It is trying multiple things until you get the desired result, even unconsciously. That is why many papers are asking for p-certified, not p-hacked. So, do not keep on changing the value till you get your own result. Now, this is important. I am going to tell you about how statistics, health statistics can be misleading. There are many ways of presenting a benefit, RRR, ARR or NNT, relative risk ratio, absolute risk ratio or NNT. Communicating relative risk as opposed to absolute risk or NNT can lead lay people and doctors to overestimate the benefit of medical intervention. I will give you an example. For example, in high risk type 2 diabetes, primary prevention with statin produces RRR of 48% in stroke over 4 years time. You think it is damn good, but actually reduction risk of suffering a stroke from 28 in 1000 to 15 in 1000, that is 13 in 1000 or ARR or OD 1.3. This is the fact actually, and NNTs need to treat is 77 to prevent one stroke. Similarly, mismatched framing in medical journals compounds the issue. If treatment A reduces the risk of developing disease from 10 to 7 in 1000, but increases the risk of disease B from 7 to 10 in 1000, the journal article reports the benefit as 30% risk reduction, but the harm as an increase in of 3 in 1000 or 0.3%. So, it is minimizing the harmful effect. 1/3 of articles in Lancet, BMJ and JAMA between 2004 and 2006 used mismatching framing. To overcome that, we must have knowledge. Knowledge is the enemy of the disease. How to survive the medical information mess? Many doctors also do not know how to survive. They are not educated. As far as the statistics, even myself, I had to study a lot to understand. It took me some time. Anything you put in PowerPoint, you say, well, that is what is very authoritative. There are some few things, statistics are not required when it is quite obvious. Significance chasing. Now, that is what the whole thing is about. You have to, whether the study is of any significance. This is producing a significance chasing bias. This publication bias, selective reporting bias, fabrication bias. Publication bias is negative results are never published, they are put under the carpet or in the cold storage. Selective reporting bias, you can twist the results and only show positive aspect. How? What I am saying, I will prove it now. So, therefore, my friends, please pardon me, I am using the term the current state of evidence biased medicine, not EBM, but EBIM, EBIM, evidence biased medicine. How? By 7 factors. Each assertions which I am making, they all will be justified by me in the subsequent minutes to come. Selective publication, rigid outcome, editorials, reprint revenues, bribery of journal editors, publication of bias, and financial conflict of interest, including doctors. This is a very good book which I read. Publication bias. In an article, a special article in New England Journal of Medicine, when it was talking about selective publication of antidepressant trials, that made it very clear such a publication can lead to unrealistic estimates of drug effectiveness, unrealistic. Fact is this, journal, all the these 12 antidepressants, their publications were in various journals and it showed good results, absolutely giving me confidence to prescribe them without any negative results. Only 2 of them showed some 3 studies only. But the fact is, you know what was the fact? When the trials completed and the data was submitted to FDA, fact was this: results of these many 31 studies were never published, only 34 were published. Think of it. Equal number of opposite results, negative results. So, it is like tossing a coin, it can be helpful or it may not be helpful. Neurology, neurodegenerative disease trials, 40% of them never saw the light of the day. 2008, 92 studies were completed, but only 14 were published, only those were published which had a positive evidence. So, evidence what you see is not the true evidence, hard evidence is ignored, good evidence is ignored, negative studies also are evidence. Now, it all comes to data, how the data is twisted. In New England Journal of Medicine, Ephesus trial, it was midway during the Ephesus trial when the endpoint was changed to benefit the trial, and the study sponsor added a secondary endpoint, death of hospital admission for cardiovascular events, to justify their intervention. Missing data. Now, this is new thing which is exponentially growing. BMJ, a lot of things started by BMJ. From 2001, it has gone exponentially high. Participants who withdrew their consent to continue participating in the trial or when missing from the data set are called missing data. One can hide a multitude of sins in missing data. When full data sharing policy was tried, 46 retrieval rate of raw data randomized trial were only there, 46%, not all of them. In New England Journal of Medicine, the Pato trial, antiplatelet trial, ticagrelor. You know what happened with that? It was published in New England Journal of Medicine, but FDA did not give approval till 2011. Why? Because 26, it documented 26 problems with the data, missing data. Then you have data fixing. When I was doing MD, I came across a book called Primer in Medicine by Papworth, which spoke of a Greek legend who would invite all the passerbys to stay in their inn, all the travelers, wine, dine, food, everything was given, but they had to sleep in a bed and they should fit into that. If they are too long, legs will be cut. If they are too short, arms and leg will be stretched. We clinicians do very often to fit the diagnosis, to fit the case into the diagnosis. And Janus phenomena, you can see both the sides. So, you can see story and change the data according to your taste. What happens to reanalysis of the data? In 2001 data set, paroxetine and imipramine were good for the adolescent, no harm, but actually on retrieving all the data and analyzing them, it was found it is no good, on the contrary it is harmful to the children. Similarly, a meta-epidemiological study was published in BMJ in 2013, which analyzed 40 trials, RCTs, and came to this conclusion that if you adjust the data, it becomes significant from 4 to 17. Then trials are on trial. We want to see whether they are pragmatic or not. Trials are designed pragmatically or not. It has to use PRECIS-2 trial, new 9 domain trial, tool, which must be used to see that your trials are pragmatic and give you proper evidence, but not this is the director of meta research and statistics, professor in Stanford University, who came to this conclusion that much of the published results are not worth it. Do the RCT really make a difference with such evidences? Let us talk of nearly 4 dozen RCTs of cholesterol reduction have reported no mortality benefit, including the recent, and after that a new trial also, accelerate trial, also showed that though it can reduce LDL cholesterol and increase HDL cholesterol, but does not change the mortality and no cardiovascular benefits. There are studies after studies, for a study of 12 years in the Western European countries, no benefit for the mortality, cannot prevent mortality. Statins, on the contrary, in Japan, when there was 50% reduction in the use of a statin after this controversy broke out about a statin use, you know what happened? After stopping it, the mortality improved. Means you can see from the stroke, from the cardiac diseases, it all improved. And these RCTs also showed that, look here, LDL cholesterol should not be lowered in 60 years plus people, because it may be detrimental to them. This was a systematic review. What I am trying to say is, if this is the evidence based, then what is the value of it? Should people at low risk of cardiovascular disease take a statin? No, because 140 patients are required to give you a benefit to prevent one stroke or cardiac attack. If you keep on lowering the LDL, what happens? LDL is lowered too much, then you produce more sugar, more eating, and also obesity and diabetes. This is known as statin gluttony. But who has benefited? People who have exploited scare, created a scare, like even professor of medicine and epidemiology at Oxford University, Professor Roy Collins. He said, well, 29% people will get it, the muscle change. So therefore, if you want to know whether you should take it or not, use my test. And it was costing $99. Then later on he had to retraction, he had to call for retraction. Now the main thing which may be hurting some of us, conflict of interest in doctors, journal editors and journal publishers. I will give you an insider's view. This is a quote from the Lancet editor-in-chief, Richard Horton. The case against science is straightforward. Much of the scientific literature, perhaps half, may simply be untrue. And chief editor for 14 years of NEJM, Dr. Relman, what he says, the medical profession is being bought by the pharmaceutical industry, not only in terms of the practice of medicine, but in terms of teaching and research. the academic institution of the country are allowing themselves to be paid agents of the pharmaceutical industry. I think it is disgraceful. That is what he said, he wrote. There was a national survey of physicians and industry relationship in New England Journal of Medicine, which said 94% of the doctors, physicians had ties to the pharmaceutical industry, 94%. So, there is a gravy train. Who are riding in the gravy train? Driven by the various industries, the drugs industry and devices industry. University professors, researchers, academic doctors, academic associations, journal editors, journals, regular doctors also. Mayo Clinic proceedings showed a very interesting graph. They came for science, they stayed for money. On an average, doctors were getting for speaking and writing $60,000 a year or so. And 37 people who were invited to give lectures, they got thousands of dollars, and one person got even $2.8 million. This is also Mayo Clinic. And Coca-Cola, whether it produces aerated drinks produce obesity or not, there were controversies, and those who were paid, who had a conflict of interest, they said 83% does not produce obesity, and those who had no interest found it to be causing obesity. Like Coca-Cola, you can see in the conflict of interest. This is what we all use, guidelines, meta-analysis. It has been said most evidence is poor. I will show you how. Total number of RCTs, do you know how they are, how much they are published? 20,000 studies every year, and it means 50 new trials are published every day. So, if you have to be updated, how much you must read? Every half an hour, day and night, so you can be updated. So, too much of evidences, and if you have too much of evidences, garbage in, garbage out, there is no quality. So, your cookies do not come up well if you cook with so many ingredients. How good is the quality of clinical evidence? This is important, which I am going to tell you. Out of 1394, almost 1400 systematic reviews in Cochrane database were put to grade, and they found 55% of the evidences were low and very low. Why these guidelines do not meet the standards and give the desired results? You can see what is written on the slide. What is to be decided by committee producing guidelines is often already decided by with the selection of the deciders. 71% of the committee chairs had conflict of interest, 91% of co-chairs had conflict of interest. Interesting example I will give you. American Urological Association said PSA best practice statement. It said PSA saves lives, but if you analyze, chairman had conflict of interest, panel members had conflict of interest. So, the government, US government set up a US Preventive Service Task Force in 2012 and found that PSA is useless. This is very damaging insider's view. Another editor, then later on who became chief editor in chief of New England Journal of Medicine, said it is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as editor. Think of it, very sad. Again same, unless your trials are based on precise tool, they cannot be pragmatic. And evidence based medicine has been changing the decisions. So, the evidence based tail wagging the clinical dog. A 70-year-old female who has been doing very well, no problem, an odd test found some cholesterol changes, was given statin, became bedridden because of the pain and could not do anything. So, that is what is called EBM, tail wagging the clinical dog. There is too much of evidence, too much of evidence. The number of clinical guidelines is so many. Can you read it? In an acute care hospital in UK, where there were in 24 hours 18 patients with 44 differential diagnoses, you know how much of national guidelines were required? 3,679 pages. And if you have to read it, it will be 122 hours of reading and relevant to the immediate care. Think of it, how many guidelines are there? And you know how the guidelines are produced. Biased evidence providers, gravity and riders, editors, publishers and impact factor. I have already mentioned evidence biased medicine. So, now I am coming to journals and the editors. In an article in PLOS, very beautifully done, must read it. Impact factor depends on turn of recent citation, as you all know, and a body of literature shows that industry sponsored trials attract more citations than those funded by non-profit sources. So, industry drives the impact factor. And reprint income, journals derive their income, total income, NEGM only 23% of their income, Lancet 41% and JAMA 53%. Think of it. So, why would they not publish the results, articles which are required? How much the editors get from industry? The bribery, the legal bribery. $15 million are paid to 35 editors every year. Think of it. JAMA, JSA, all, there are only 6 are mentioned, but every editor has got something or the other, most of the editors. With the result, they are more concerned with highlighting the issue. The drug is effective in lowering the sugar, do not bother about the heart attack which occurs. Then we have to see editorial is the best practice. This is like this example where authors are all on the conflict of interest, they are even paid employee. You can create a biased evidence. If it is show that parachute harm, do not jump from the here, that will be control, jump from the stationary plane. Most findings are false. We have some of our colleagues who had entered the hall of defame, like Sloan Kettering, chief, who would get $3.5 million with conflict of interest. Some doctors who said this medicine is good. But now we come to practical problems. I have shown you how the different biases are produced. Practical problem. Overemphasis on following algorithmic rules. How can we ensure that everyone in a different denominator population is taking statins? Things like that, which is going to benefit industry. Template driven misses unique symptoms. Now, managerialism creeps in when we have algorithmic protocols, templates. Then it improves the graph, financial graph, and bureaucratic rules become the accepted way to implement the best evidence. Become the best evidence, how to implement them. So, this cartoon is very correct, which says, but you let the insurance companies tell you what to prescribe. A cookbook medicine, poor fit for multi-modality, the conflicting guidelines, and because already benefit was given, there are small marginal gains are there, and that is why large trials are designed to show that marginal gains can be utilized. Again I come back to the same article, editorial by David Sackett, only the profounder, the pioneer of evidence based medicine. The two pillars, patient integrity, the clinical expertise and the external evidences, the research evidences, experimental evidences. David Sackett has also called individual clinical expertise He described this as reflecting the proficiency and judgment that physicians acquire through clinical practice, not the protocol, not the rules, not the bureaucratic rules, not the algorithmic rules. Therefore, the balance is tilted against physicians. There is illusion of innovation in new drug approved by FDA. In 8 years, only 11% were truly innovative, rest find the new bottle. Some changes here and there and to market it. Then what are alternatives to EBM? Evidence based medicine, which is to be there. Vehemence based medicine, too much literature, you quote this thing, you quote that thing, and say this is the correct thing to do. Or eloquence based medicine, very well dressed, very talkative, jugglery, and you can get the patient treated. Or NBM, nervousness based medicine, they are worried about the litigation, so they are very nervous, they must report to the take recourse to the algorithmic protocols. So, you have to decide which one you have to choose. Well, as Winston Churchill said, democracy is the worst form of government except all the others that have tried. So, EBM is the worst, but there is no other alternative. We have to use it, we have to see that clinicians factor improves there. And once you start doing like that, going against EBM, you are likely to be attacked, and you have to develop a thick skin like rhinoceros. But in my life, I have found silence becomes cowardice. I follow Mahatma Gandhi. Silence becomes cowardice when occasion demands, is speaking out the whole truth and acting accordingly. So, this is the way I have given you evidence, because it is better to be a lonely lion than a popular sheep. Thank you. Thank you.
Thank you, Professor Amitav Verma, the president of DNA, for providing an insider view of the malpractices that is happening with the evidence-based medicine in today's medical world. And I think with the growing availability of the drugs available for neurological disorders, your lecture is most suitable to the youngsters who are listening to this lecture to have a proper judgment of deciding that which one to choose and based on what kind of evidence. So may I request Professor Gauri Devi, if she's there, to kindly say a few words and felicitate our president of DNA, Dr. Amitav Verma.
Dr. Amitav Verma, it's remarkable, superb oration, the way you have put forth the ideas, the publications, evidence-based medicine or biased medicine. Remarkable. I've yet to hear such an oration for a long, long time. And it looks as if you have really done a lot of research looking at highways and potholes, and gave a huge panoramic view of the whole discipline of evidence-based medicine, statistics, conflict of interest, financial issues, and so on and so forth, and of course the legal issues. Remarkable, Amitav. Congratulations for an excellent presidential oration. God bless you.
May I request Dr. Chabra to say a few words? So I think he is not available at the moment. No, he's available. Dr. Chabra.
Yeah,
Yes.
Can you hear me?
Yes.
Yeah. It was a wonderful oration. Really very impressed by the depth of knowledge and science which Professor Amitav Verma showed us. Remarkable. I congratulate him for the wonderful oration. Thank you, sir. Thank you very much.
Thank you, sir. So may I request Dr. Achal Srivastav to kindly present the presidential oration plaque virtually to Dr. Amitav Verma. Dr. Achal, do you have a replica? Yes. So ladies and gentlemen, wherever you are, virtually you do a clapping for a beautiful and very important and timely lecture by our president, Dr. Amitav Verma. And we are thankful for him to taken up this topic, which are still a voodoo in the medical parlance, and therefore enlightening us on this subject. Thank you. Thank you very much. With this, we conclude the presidential oration. And now I hand over the microphone to Achal Srivastav.
Thank you, sir. After this very knowledgeable and I will say fantastic session,